Hello again, we're back. This is going to be your last lesson, your last lecture video lesson, and it's about the Affordable Care Act of 2010. This is also popularly known in the press and often referred to as Obamacare. It did start out, that nickname or that moniker started out more like on a negative manner, derogatory, if you might call it, but now it's a more accepted terminology, and people actually, you know, refer to it as Obamacare, whether they have positive or negative views about the law. Okay, so before we get into specific provisions of the law, it will be helpful to understand what the law itself wanted to achieve. A lot of people can agree that there are so many underlying problems with our system. When this law was launched in 2009, the previous year before that, in 2009, no, the law was basically launched in 2010, but the previous year, in 2009, there were 50 million citizens and residents of the United States that do not have health insurance or are underinsured. Underinsured are people who have health insurance but do not have a comprehensive enough coverage to cover their healthcare needs. There was also a lot of fragmentation in the healthcare systems, and it led to duplication and inefficient care. Uh, Healthcare costs was also skyrocketing, um, although later on data would suggest that it sort of uh, stabilized a bit because of at the time we were at the tail end of the economic crisis of the late years of the uh, from 2008 to 2009. There's so many proposed solutions. We don't agree on all solutions, but the fact is this law has overarching goals, and it's to address all those fundamental problems that I have just mentioned. So the goals cover four key areas. The first being expanding coverage to the millions of Americans who don't have it today. Second is to improve the affordability and quality of the coverage for those who have it. Third is to improve access to overall quality of care that individuals receive. And of course, constrain the growth in healthcare costs. So this law includes numerous provisions designed to address each of these goals. The health reform law seeks to expand health coverage by building on the existing public-private system for providing health insurance and filling in the gaps in the current system. So it wants to expand the eligibility for the Medicaid program. We're going to talk more about this because uh, in slides later on, I will explain that not all states are actually expanding their Medicaid program, but it was one of the key uh, parts of the law that was intended to expand coverage. So states were expected to expand eligibility for the Medicaid program, um, and also create exchanges or marketplaces where people can purchase coverage. And depending on their income, they're going to get some subsidies from the government. It also includes new penalties for employers that don't offer coverage to their employees, and then rewards or gives tax credits to small employers that decide to offer employer-sponsored coverage. Supporting this enhanced coverage mechanism is the new requirement about individuals called the individual mandate. We will again discuss this, the individual mandate, because there was a law in late 2017 that sort of basically negated this. The law also requires insurers to provide coverage to everyone, regardless of health status, and limiting the variations in premiums they charge people if they buy their or seek and try to get their health insurance from this marketplaces. So together, if taken all together, these strategies are designed to increase significantly the number of people with health insurance. So let's go back a little bit to this because I want to emphasize the basis is that a lot of Americans already have health insurance through their employers, right? So those of us who are lucky enough to get coverage from our employers, this is what the law builds on. Now, there are some people who qualify for Medicaid. So basically, what this means is that the law expands Medicaid, so there will be more people that will qualify for Medicaid. Now, you cannot apply for Medicaid if you already have this employer-sponsored coverage. So this is meant for people who can't get employer-sponsored coverage or they can't buy their own insurance because they also can't afford it. But if they earn up to 138% of the federal poverty level, they can then be covered by Medicaid. For those people who do not have employer-sponsored coverage but do not qualify for Medicaid, the law says there should be marketplaces where people can shop for health insurance. This was an original provision of the law requiring people to buy health insurance if they don't get it here or they don't get it here. And this happens by buying health insurance in the health exchanges. That then results to increased health coverage, more people being covered. But within the law is health insurance market reforms. And, that's improving the types of minimum benefits, for instance, one can get if you buy your health insurance in the health insurance exchange, which actually covers all types of health insurance as well. So to begin to fill the gaps in coverage, what were the early actions? So as early as 6 months after it was enacted in March 2010, so that means as early as September of 2010, the law made some small changes in our healthcare system. To provide immediate coverage to individuals with medical conditions, the law created the pre-existing condition insurance plan. So this is a high-risk pool available in each state. Individuals are eligible if they have a pre-existing medical condition and they cannot basically afford to buy their own health insurance. So to make the coverage in this plan more affordable, the premiums will be set as if the enrolled population was not sick, meaning their premiums will be lower and it's sort of at par with the rest of the healthy population. The risk then is paid for by the state. In some cases, the premiums will still be unaffordable though for people who need the coverage. So the program is federally funded and will be available until the new health insurance exchanges are up and running in 2014. Targeting the young adult population, which has the highest risk of any age group of being uninsured, the law allows adult children to remain on their parents' insurance policy until age 26. So they can be under their parents' policy until the very last day of their 25th year of age. Adult children do not have to live with their parents or be claimed as a dependent on their parents' taxes to be eligible, nor do they have to be students. They can also be married, although their spouse and their children are not eligible to be under their parents' healthcare coverage. Let's talk about the Medicaid expansion. So much more significant coverage expansions have occurred in 2014. So in 2014, the law expanded the Medicaid program to cover nearly all individuals with income up to 138% of the federal poverty level, which I will be showing in a table later on. So this expansion creates a uniform eligibility for threshold for Medicaid across the states. At the time the law was put into place, the eligibility threshold was 133%. Now, what changed this was that in June of 2012, the Supreme Court, in a subsequent June 2012 ruling, the Supreme Court allowed the states to opt out. So that means it allowed the states to have a choice whether they want to expand their Medicaid coverage or not. And the next slide shows which states have expanded their Medicaid programs and those that have not as of March 2020. So as you can see, the blue ones are those that adopted. So as of March, there were 37 states, which includes the District of Columbia. And these are the states that have not adopted at this time. This actually has increased over the years, the number of states that have adopted their Medicaid program, which is a good sign. Basically, if a state chooses to expand their Medicaid program, they receive additional funding for their Medicaid grants from the federal government. Other provisions to expand health insurance coverage in 2014, the law created new state-based health insurance exchanges or marketplaces where individuals and small employers can purchase the coverage. So these exchanges will allow individuals to compare plans and select the one that best meets their needs. To ensure that coverage in the exchanges is affordable to most consumers, starting in 2014, premium subsidies will be available to those with incomes up to 400% of the poverty level. So let's look at that federal poverty level table in this slide. So here's that difference. If you live in a state that has expanded their Medicaid program, one person household, you can earn as much as $17,609 in 2020 and be eligible for Medicaid. If you live in a state that did not expand their Medicaid program, this is your maximum amount. So you can earn as much as $16,971, almost $17,000, if you live in a state that did not expand Medicaid and be eligible for Medicaid. But if you live in a state that expanded their Medicaid program, you can earn as much as $17,609. Now, let's talk about the subsidy. Single person household, if you earn up to 400% of the federal poverty level, which is $51,000 for a single person household, you will be eligible for a government subsidy to help you pay for the insurance that you bought in the health insurance exchange.